Alrighty, today we're going to go over EKG basics as well as some cardiac anatomy, including both your mechanical anatomy, your electrical anatomy. We're going to go over a little bit of Einthoven's triangle, a little bit of the cardiac action potential. Finally, we're going to review some four-lead rhythms. So at the end of this course, you should be able to identify key structures of the heart's anatomy, as well as explain their function and relationship with the EKG waveforms. You should be able to give a brief overview of cardiac action potential and its relationship with the four-lead EKG as well as its waveforms. You should be able to identify and explain different parts of the four leads, such as your waves, your segments, how they should look, what's going on when they don't look that way. And then finally be able to identify the reviewed four-lead rhythms. We're going to start off today with going over some of the mechanical anatomy of the heart. We're going to take a look at the inside of the heart as well as the outside of the heart. Alright, so starting off with your vena cava. You have two of them. You have your superior vena cava and your inferior vena cava. These supply blood from the body to the heart. They are veins, and the inferior vena cava brings used blood up from the bottom of the body, and the superior vena cava brings used blood down from the top of the body. Your heart has four chambers, 1, 2, 3, 4, separated into two categories. You have your atrium and your ventricles. You also have several valves going throughout your heart. These two are separated into two separate categories. You have your atrioventricular, or your AV valves, also known as your tricuspid valve, and your bicuspid valve. You also have your semilunar valves, which are your pulmonary valve and your aortic valve. Those prevent backflow either up into your atrium or back into your ventricles. Or not your ventricles, excuse me, or into your arteries. Next, we'll go into our arteries and veins. So you have your pulmonary artery right here. This will take used deoxygenated blood from your right ventricle to your lungs. This is the only artery in your body that will take deoxygenated used blood in it. It still goes away from the heart, so that rule still applies. The artery away, or artery A away, taking blood away from the heart to the lungs. But you just have to remember that this is deoxygenated blood. It has not yet gone back to the lungs to be refueled. Then it'll go off to the lungs and come back to the heart via your pulmonary veins. Same thing with the pulmonary artery. These are the only veins in your body that carry oxygenated, refueled blood. Still, same rule, the veins carry blood back towards the heart, applies here. They'll drop off that blood in your left atrium, and then your left ventricle does the same general function as your right ventricle, delivering blood through your aortic valve into the rest of your body. Any questions on the interior mechanical anatomy of the heart? And then we're going to go into the external anatomy of the heart. You'll see some overlap with the structures that we already discussed in the previous slide, as the vena cavas here, your aorta here, you got your atriums and your ventricles. But what we're going to focus on for this outside view is going to be the coronary arteries. This is how your heart gets its blood supply. So just like any other organ, it has to have its own kind of blood supply. It doesn't mooch from the blood going into it. So these will be, as you can tell, they come off of the aorta here. So when your heart is in diastole, these will actually fill and supply your heart with blood. So they supply different areas of the heart, and what coronary artery supplies where is important to note, as it will cause different problems if there is a lack of blood supply to that. Starting with your right coronary artery, this coronary artery supplies the right side of your heart, your right atrium and your right ventricle. It supplies about 1/3 of the blood supply to your intraventricular septum, which is this space between your two ventricles. And it, importantly for talking about electrical activity, it supplies your SA node and your AV node. We'll go more into what those nodes are, but they're kind of the starting process of your electrical activity in the heart. And then you have your left main coronary artery, seen right in here. It pretty quickly will split into two separate coronary arteries. Your left interior descending coronary artery goes here and supplies that left side of your heart. So your left atrium, your left ventricle, most of the rest of that intraventricular septum. And then it goes into the circumflex artery. Not really pictured here, but you can see a little bit of it right there. It goes around that back side of your heart, supplying all the blood to that back side of your heart. So again, important to note that that right coronary artery does do a lot of blood supply for the electrical system. We've already gone over this, but just to go over it in a little bit more detail, the blood flow through the heart. Important to note that with this blood flow through the heart, your systole, which is when your heart is pumping, and your diastole, when your heart is at rest, what your valves are doing. Scroll back to the valves. So during diastole, or when your heart is at rest, when it's not pumping, just when it's getting filled with blood, your AV valves, your atrioventricular valves, are going to be open, allowing blood to freely pass through them. So that allows blood to go from your atrium directly into your ventricles without that having to be opened. And then your semilunar valves are closed during diastole, and they open during systole, allowing your ventricles to push blood into that next organ or body. So, blood flow through the heart. You start at your vena cavas. They dump into the atrium. During diastole, this filling, your AV valve is open, allowing blood to go into your right ventricle. You then have what's called atrial kick, or your atrial contraction, which happens just directly before your ventricular contraction, and this just gives all the little blood that's sitting in your atrium a nice squeeze to get out and into the ventricles, so you have adequate preload in those ventricles to supply blood wherever it's going. Then you have ventricular systole, or contraction, when these AV valves close, squeeze up into your pulmonary artery, go into your lungs, back through these pulmonary veins, into the left atrium, through the mitral valve, or bicuspid valve, into that left ventricle, and again, heart will squeeze, and that will push blood up through your aorta into the rest of your body. So really fast, it goes your vena cavas, right atrium, tricuspid valve, right ventricle, pulmonary artery, lungs, pulmonary vein, left atrium, through the bicuspid valve, into the left ventricle, then to your aortic valve, and through your aorta. So now moving on to different layers of the heart. The heart is a muscly organ. It's primarily muscle, but it does have different cellular layers. We're not going to go into the deep cell makeup of these layers, but more so talk about their general function. And again, I apologize that on this video you can't see this very well. I do have the video, the PowerPoint linked. So your epicardium is the outermost layer of the heart. It's made primarily of connective tissue, and it is attached to a degree to your pericardium, which is the sac that your heart lives in your thoracic cavity. So its main function is to prevent friction damage to your heart. So your heart's beating all the time, 365, 7 days a week. the entire time you're alive. Imagine if you did this with your hands, rubbing up against each other, the entire time you were alive, without anything between them to protect them. It would cause a lot of irritation. You would end up with some swelling, skin breakdown, tissue breakdown. The epicardium, along with some other things, helps to prevent that happening to the heart as it's beating in your chest, touching your lungs, your diaphragm, anything else in that cavity that it could be rubbing against. The epicardium does play a large role in protecting it against friction damage. Then you have the myocardium, which is this middle layer here, that is primarily made up of your muscle tissue. This is going to be the workhorse layer of your heart. It's going to be what's doing all of that squeezing and contracting and moving all that blood around. It's made primarily up of muscle tissues. And then finally, you have your internal layer of your heart, your endocardium. Your endocardium plays a very similar role as your epicardium does. Its role is to prevent blood cell clotting inside of the heart. So it is a nice smooth layer that allows blood to just slide right off of it like a slip and slide. It is cohesive with your vasculature's endothelium layer. So your veins have 3 separate layers, as does your heart. And that internal layer of your vessels is called your endothelium. Your endocardium and endothelium are cohesive, which again helps prevent cell clotting and turbulent blood flow going between the heart and the rest of your body. Okay, any questions about anything we've gone over thus far? So now we're going to go into electrical cardiac anatomy. So as you can see, this looks just like the internal slide with the addition of these yellow structures. These yellow structures are what we are going to be talking about, as that is your electrical anatomy. And these produce those impulses that we're going to be interpreting in our foreleads. The previous structures noted, such as your atrium, your ventricles, are all supporting members of your electrical activity. Without them, your electrical activity of your heart wouldn't have anything to tell what to do. So these impulses are what causes these contractions in your heart and create a heartbeat. So starting at the SA node, this is normally the heart's intrinsic pacemaker if everything is going right on just a normal day. This is where your cardiac impulses originate, from that SA node. It sits in your right atrium near where that superior vena cava dumps its blood, right there. So SA node, superior vena cava. It sits right on top of your right atrium. Remember that we said that your right coronary artery feeds that because it's on the right side of your heart. It sets the intrinsic rate, and that is normally between 60 and 100 beats per minute. Do note that that is the same, healthy rate, normal rate of your adult heart rate. It's because when everything's going right, that's the node in charge. You then go down to your AV node. So impulses go to your atrium, travel down to this AV node. The AV node's function is to briefly delay cardiac impulse, so you can have that atrial kick we were talking about earlier, where your atrium squeezes just before your ventricles do, creating this kind of motion in your heart, and allowing adequate preload into your ventricles. It does this because the inside of that AV node is kind of built like a roundabout, and the impulse goes around it to get back into your bundle of His, which is the next stop on the electrical's path. This bundle of His goes down and into both of your ventricles. When it diverges and splits right here, it creates your left bundle branch and your right bundle branch that innervate their respective ventricles. From these bundle branches, you go into your Purkinje fibers, noted in these little tiny dudes. Those are specialized cells that can quickly and effectively spread the electrical impulse throughout the entire ventricle, so it all contracts at one time like it is supposed to and have uniform motion, that those Purkinje fibers are the last cell structure on the way to the individual muscle cells, delivering all of that impulse. So now we're going to talk about cardiac action potential, what it is and how it relates to your waveforms in your Four-Leaf and 12. So what is cardiac action potential? It is the way that cardiac muscle contractions happen. It is the tracking of what is going in and out of the cell during electrical impulses, as well as the voltage change in those cells. So this is a diagram of said action potential. You start here at baseline, which is resting potential for your cells. That is the voltage level that your cells are sitting at when they're not being stimulated. And then you go up to phase 0, which is rapid depolarization. This is a rapid increase in your cell's voltage, and that is the start of your contraction, or the electrical activity that should be causing your contraction. It starts when the cells receive that impulse. It has a fast opening of sodium channels that allow a rapid influx of sodium into the cell, which helps increase that cell's voltage. Potassium is slowly leaving the cell, and calcium is slowly moving into the cell. This is shown on our 12 lead by the P wave for atrial depolarization and the QRS complex for ventricular depolarization. Now we're going to go on to phase 1, which is this little purpley pink section right there. It is early repolarization, so you can see how on this graph, this is your increase in cell voltage, and right here is just the initial little dip in your cell's voltage. This happens because those fast sodium channels close, slowing down that sodium going into the cell. You still have some outward movement of potassium, but overall it just results in that decrease of charge in your cell. This does not show on your waveforms. Now going on to phase 2, this green plateau phase. Repolarization is slowly continuing. There is a slow inward movement of calcium. There's a slow inward movement of calcium and a slow outward movement of potassium still. This is shown on your EKG as your ST segment, right here. And do note that this drawing of your waveforms is exaggerated to match up there. So ST segment would match that green line, your P wave QRS matches where your rapid depolarization is. And then moving on to phase 3, this is rapid repolarization. This is where your cell rapidly returns to its baseline. It does that by potassium quickly leaving the cell, your slow ion channels for your sodium close, and the influx of calcium stops. This is shown in your 12 lead by your T wave. And it is the final phase before your cell returns to its resting potential and is fully ready to receive another impulse. We're going to go over some refractory notes that occur during this action potential cycle. So to start off, refractoriness is the extent in which a cell is able to respond to external stimulus. So this whole process is your cell responding to external stimulus. Where your refractoriness is how willing your cell is to do all of this. So when it first depolarizes, and when you're here in this area, that is your absolute refractory period. No matter how strong of an impulse, there is going to be no restarting this until we get into the lower section of phase 3, which is also noted as the last half of your T wave. And then you'll see, as demonstrated here, during your rapid repolarization, cells have a tendency to dip below their resting, and that is known as supernormal non-refractory period. So a weaker than normal stimulus can generate all of that starting again. So now we're going to go on to Einthoven's triangle. This is the theory or the law with your limb lead electrodes, how the positive and negative leads function to create their given outputs. So down below, you can see what electrodes are positive, what electrodes are negative. You'll note the right leg is not listed on there, as that does not factor into any of these leads. It's more just like a stabilizing electrode that helps decrease our artifact. So your positive electrodes would be your left leg, your left arm. Your negative electrodes are your right arm. In V, so this does change based on what lead you're looking at. Your left arm can be negative or positive depending on what lead it's in. When you're in lead 1, it is a positive electrode. When it is in lead 3, it is a negative electrode. In this, so how these leads work is they measure the difference between the two electrodes of what they're looking at, and that makes them a bipolar lead because they're using 2 electrodes. And those bipolar leads are only your leads 1 through lead 3. Your AVL, AVF, and AVR are augmented unipolar leads, and they use your heart and then that lead to look at the electrical activity. They don't bounce off of 2 different leads. So lead 1 looks at the lateral wall of the left ventricle. Lead 2 views the inferior surface of the left ventricle. And lead 3 views the inferior surface of the left ventricle. Your AVL, or your augmented vector left lead, visualizes the left lateral wall of the heart. Your AVF, otherwise known as your augmented vector foot, looks at the inferior wall. And your AVR, augmented vector right, it's kind of no man's land. It doesn't directly visualize a surface. It more so just views the wave of depolarization. Alrighty, so now we're going to talk about waveforms. Now that we understand all the anatomy and the systems that go into creating these and what we're actually looking at in these, we're going to go into what they're supposed to look like and how to use them to determine what rhythm you're in. So just a brief overview of the waveforms. Your P wave is your atrial depolarization, so it's that phase 0 of your action potential for your atrium. Then you have your PR interval, which is the space between the start of your P wave and the start of your Q wave, and that represents the conduction of electrical activity through the AV node. And then your QRS is your ventricular depolarization. And then your ST segment is the time between ventricular depolarization and ventricular repolarization. Remember when we looked at our chart for action potential, that would be your plateau phase into your repolarization phase. And then your T wave is ventricular repolarization. We don't see atrial repolarization because it's covered up by the larger electrical output of ventricular depolarization. Alright, so now we have a chart of what each waveform is supposed to look like on a regular good EKG. So you have your P wave, which in a normal setting should be less than 0.12 milliseconds. Sorry, 0.12 seconds. That would be 120 milliseconds. Or 3 of the little baby boxes on your EKGs. The normal amplitude being how tall it is less than 2.5 millimeters, which that translates into how much electrical activity is being shown. In your limb leads, which are your leads 1 through 3, and then your AVF, AVL, AVR. In your V leads, it should be no taller than 1.5 millimeters. The normal morphology of your P wave is nice, smooth, and round. It should be pretty symmetrical and just one nice bump, as you can see it there. That would be your normal P wave. It's allowed to be a little bit asymmetrical, leaning a little bit to one side, but for the most part, you want it nice, smooth, and rounded. So your PR segment should be between 0.12 and 0.20 seconds, or 120 to 200 milliseconds. It should be isoelectric, which basically means it lines up with all of this. When we go look at 4-lead rhythms, we'll talk more about what it means to be isoelectric. For most of our interpretations today, it's not as critical. And then going on to our Q wave. It is normally 40 milliseconds or 0.40 seconds. It does vary between leads. For today, we're just going to go with it as normally 0.40 seconds. For amplitude, it doesn't get a specific number, but it is in relation to your R wave. It should be about it should be less than 25% of your R wave's amplitude. And it is the first negative deflection. So you have your P wave, which is a positive deflection, and your Q wave is that first little negative deflection. And it should be less than 20% of this large R wave. Your R wave, its regular length and regular amplitude varies heavily between each lead and just depending on what's going on in the heart. But it is the first positive deflection after your P wave. As we just saw, P, positive deflection, Q, negative deflection, R wave, next positive deflection. Your S wave varies similarly as your O wave does, so we're not going to give it standardized times or heights, but it is the next negative deflection. So it's the negative deflection after your R wave. I see that, right there. Your ST segment is isoelectric, the same as your PR segment is. It doesn't have a stated length or morphology, minus the fact that it is flat and usually isoelectric. And then last you have your T wave. Your T wave relates to the QT interval for how long it is. So we're not going to define it a standard. And then your regular amplitude is between 5 and 10 millimeters, and it depends on the lead. So it again is one of those that varies based off of where in the heart you're looking at it. It is normally rounded, slightly asymmetrical, very similar to your P wave in presentation. It will have a greater amplitude than your P wave, but in morphology it is domed and a little bit asymmetrical. And that asymmetrical just comes from your left ventricle being heftier than your right ventricle, so you have a little bit more oomph to your electrical in that latter half of your T wave. So now going into rhythms. So remembering everything we went through and why certain things are happening. So the first chunk of rhythms that we're going to talk about are our sinus rhythms. You have Normal sinus, which is what you would expect someone to be in when you take a picture of their electrical activity. This is your normal, like, baseline rhythm. If you were to take a 4 lead of me right now, it should be what I am in. So that your stats for that are a rate between 60 and 100. Your rhythm is regular, so everything should march out nice and regularly. Your P-wave presentation is normal, and you have a 1-to-1 ratio, so 1 P-wave to 1 QRS complex. Your PR interval is that normal between 0.12 and 0.20 seconds, and your QRS has its normal morphology, which is less than 0.10 seconds. And it will look like that. So you got your normal P waves, your normal QRS, and your normal ST, and it should be anywhere between 60 and 100 seconds. So real fast, how to count time on your EKG strips is going to be find you a QRS. If you can find one that lines up with the thicker box line, that does make counting a little bit easier. There's more than one way to do this. This is just the way that we're going to talk about today. And then you count how many big boxes it is to the next QRS complex. So like in this bottom one, we're going to choose this QRS because it lines up nice and perfectly. That one box, if your next QRS was right there, that would be 300. This next box is 150. The one after that is 100, and then 75. So 300, 150. We're gonna say this is like right around 120 beats. There are ways to get a lot more specific, but for today's purpose, we're not going to go into those. So that was normal sinus. Now going on to sinus bradycardia. It is exactly the same as sinus rhythm minus the rate. This rate will be less than 60 beats a minute. So the only change between your sinus rhythm, your normal sinus rhythm, and your sinus bradycardia is going to be the rate. Your normal sinus is 60 to 100. Sinus brady is anything under 60. Talking about sinus tachycardia, same concept. It is exactly the same as your normal sinus. Its rate is just faster. Its rate will be anywhere between 100 and 150. So that little red line is going to be your sinus tachycardia. And then we have something called sinus arrhythmia. This has the same rate as your normal sinus, 60 to 100, but it'll have, not everything will march out perfectly. Some of your QRSs will be a little bit closer together, some of them will be a little further apart. This is a normal, benign rhythm in most people, and most pediatrics you'll find this in, and most younger adults you'll find this in. So you have your sinus rhythm up here with your textbook P wave, textbook QRS, and textbook T wave at a rate of 60 to 100. Then here you have your sinus tachycardia. Everything should still look as the book has told you, and it'll just be a little bit more fast. So it'll be between 100 and 150 beats a minute. And now you have your sinus bradycardia seen up here. Note how far apart they are and use your methods of counting to show you how far that actually is. Should be right around 30 beats a minute there. And then you have your sinus arrhythmia down below, and you can just note these two are a little bit farther apart than those two. These two are a little bit more far apart than those, and like especially that has a pretty large gap in between there. Remember that this is just a normal finding in your pediatrics and younger adults. So now we're going to go on to two things called sinus block and sinus arrest. Sinus block and arrest are going to be slower rhythms. They're going to be less than 60 beats a minute typically. they're going to be regularly irregular, so they're going to march out normally, and then they'll have a beat where they don't. So with your sinus block, your P waves march out at a 1-to-1 ratio, just like you would expect from a sinus rhythm. And when you have a dropped QRS, you can still have a P wave. If you take your calipers and put them like between those, it would march out every time. And then when you get to this block, you'll have a block where you'd expect one, and the next one to come in. So this one you're missing 2 beats right in there. And then on your sinus arrest, they won't march out. It's not like a temporary block in your AV node like your sinus block is. It's just a little pause. So that won't be as textbook marching out. The sinus arrest, you also expect a rate less than 60. It is still regularly irregular, despite the fact that they don't march out. When you have P waves, you expect them to look normal. Your PRI should still be between 0.12 and 0.20 seconds, and your QRSs should still be nice and narrow. And again, that bottom one is an example of sinus block. So going on to some junctional rhythms. Your standard junctional rhythm, excuse my cat, sorry. Standard junctional rhythm is a rate between 40 and 60 beats. It's a regular rhythm, so everything should march out how you expect it to. Again, if you take your calipers and just like twist them over to the next one, it should all line up. The P waves heavily vary in your junctional rhythms. It depends on when your atrium are depolarizing. So if they're depolarizing before your ventricles, they're not going to be depolarizing before your ventricles. So they're going to be inverted if you see them before your QRS. You're also likely to just not have P waves in a junctional rhythm, and that will be because the atrium are depolarizing kind of at the same time as your ventricles, so they're hidden inside of that QRS complex. And if you see a P wave after your QRS, it'll be upright, look like a normal little P wave. If your PRI or your interval between your P wave and your Q wave is there, it will be less than 0.12 seconds. And your QRSs are still nice and narrow at less than 0.12 seconds. That's your junctional rhythm. These next two rhythms, the only difference in them is going to be their rate. So your accelerated junctional is going to be between 60 and 100. This oftentimes will look very similar to sinus rhythm. You'll have to look at your P waves to determine the difference between sinus rhythm and accelerated junctional. And then your junctional tachycardia is even faster than that accelerated junctional. It's otherwise known as JTAC. And you'll see the rate anywhere between 101 and 180. And again, the P waves are the same for all of these. If they're before the QRS, they're going to be inverted, which just means they'll have a negative deflection instead of a positive deflection. They could be hidden inside of the QRS complex, and if they're seen after the QRS, they'll be a positive deflection or upright. All right, and now some examples of these. This first strip is your normal junctional rhythm at a nice slow rate between 40 and 60. In this strip, you see the P waves before the QRS, so they are inverted. And then your next one is a accelerated junctional rhythm at a rate between 60 and 100. This one again has your inverted P waves. And then below it, you have your junctional tachycardia. This one, your P waves are hidden. This little red line shows you kind of where they would be if they were there, but instead they're happening during that QRS complex. Going on to some other atrial originating rhythms, you have a wandering atrial pacemaker. The only difference between a wandering atrial pacemaker rhythm and your normal sinus rhythm is going to be the morphology of your P waves. P waves are going to have different morphology in each little section as denoted here. Like each of those P waves just look different. It's because they're coming from a site that is not your SA node. Everything else about it is similar to that of a normal sinus rhythm. Then you have atrial fibrillation, which is going to be one of your few irregular rhythms. And that could be noted as this top rhythm. You don't really have any organized atrial activity. Your atrium are kind of just quivering there. They're not doing the boop, boop. They're doing kind of like a this, and then your ventricles are organized. So this, organized, organized. So you'll still see your QRS complex and your T wave, but you won't see any kind of P waves. And then you have your atrial tachycardia. That is a rate between 150 and 250. And everything else on that is going to be very similar to like a sinus tach. Your P waves are going to get really hard to distinguish here just due to how fast the heart is beating, and you're going to likely see no T waves or your T waves as part of your no P waves, or your P waves will appear inside of your T waves, and that's simply due to how fast your heart is beating. Your QRSs remain narrow in all of these at less than 0.12 seconds or 0.10 seconds. And then you have atrial flutter, which is really similar to atrial fib, but instead of your atrium just kind of quivering there, they're beating more rapidly than the QRSs. So you will have different numbers of P waves to your QRS. So your P to QRS ratio could be anywhere from, let's say, 3 P waves to 1 QRS. It could be 2 P waves to 1 QRS. It depends on just how fast each are beating. So you won't be able to determine your PRI. Your QRS complexes still are narrow. There will be multiple P waves, but their morphology should be the same. You can see that on that second strip set. This is a 2:1 ratio throughout, so you have 2 P waves per your 1 QRS. Now we're going to start talking about AV blocks. These will get kind of confusing. We're going to go over them for a little bit longer. So on your first degree blocks, the rate varies. It should be similar to that of a normal sinus rhythm, but it will determine based off of what rhythm your heart is in. So this is a tach-on rhythm. So you'll note this, but you still have to say the underlying rhythm. This itself is not a rhythm. You identify this by your PRI being longer than 0.20, 0.20 seconds. So you'll see just a very elongated PRI. So you'll have your P wave, multiple boxes, and then a QRS. And that is not a rhythm all on its own. It's a factor that you tag on to that baseline rhythm. So in this example, this would be this top one. This would be a sinus rhythm with a first degree AV block. And then you go into your second degree AV blocks. Second degree type 1 AV block, you're going to see a longening of your PR intervals. They'll start out more on the normal side, and then they'll get longer and longer until you have a completely dropped QRS. So, such as this, you can see the little notation down here showing how long your PRI is, and then you miss the QRS complex. And then you start all over again with your PRI getting longer and longer and longer, and you miss a QRS complex. So that is your second degree type 1 AV block. These are also known as a Winky-Bach block. And the slide's going past a little bit. It's a little poem that we'll go over once we talk about all 4 of these blocks. Then you have a second degree type 2 AV block. This is very similar to your second degree type 1. The only difference is instead of your PRI increasing, it'll stay the same, and then you'll just have a missed beat. So, same PRI, same PRI, same PRI, P, no QRS. So you're missing that whole QRS complex, but your PRI stays consistent. And last, we have a third degree block, which is also known as a complete heart block. In these, your atrium and your ventricles are not talking to each other. They're doing their own thing. So you're going to have P waves and you're going to have QRSs, but they're going to have no correlation with each other. You're not going to have any PRI. You're not going to have a 1-to-1 or 2-to-1 ratio for your P wave to your QRS. But your P waves individually will march out. So if you take your calipers, pick a P wave, pick the next P wave, and roll it, you'll find your next P wave. Your QRS complex will be the same way. They'll march out, but they're not going to have any sort of relationship with your P wave. A fun little poem to remember this, which helped me tremendously when learning it, is up on the screen. I'll read it out for you. If the R is far from the P, then you have a first degree. Longer, longer, longer drop, then you have a Winky-Bach. If some P's don't get through, then you have a Mobitz 2. If the P's and Q's don't agree, then you have a third degree. So again, Winky-Bach is that second degree type 1 with the longer PRI intervals until you just miss a QRS complex. When it's saying some of the P's don't get through, that means that it hasn't gotten, the impulse didn't get to your ventricles. And that Mobitz 2 is another name for a second degree AV block, type 2. And then the P's and Q's not agreeing, that's, as we were saying, they have no communication going on between them. Again, the top strip is a first degree block. I know it's a 12 lead. You can look at your limb leads up there. I can find a good 4 lead strip. And then you have your second degree type 1 down below where the PRI is getting longer, longer, and dropping. And then here, the top one, you have a Mobitz 2 or a second degree type 2 AV block. Down here is a third degree where they're just not talking to each other at all, but if you march it out, they line up. If you march it out, they line up. Jake. Alright, and then you have idioventricular rhythms. These are going to be your idioventricular rhythm, just baseline is going to be at a rate between 20 and 40. You won't have any atrial activity. You will only see ventricular activity, which means you will not have a P wave. That's seen at this top slide right here. Notice no P waves, incredibly far apart, incredibly slow. And then you have accelerated idioventricular. Again, you're not going to have any P waves. So that's accelerated idio right there, and then right there. It kind of goes back internal the rhythm for a second. It's going to be between 41 and 100. Again, no P waves, but your QRSs are going to get a little bit wider. Alright, and now we have our code rhythms. Your ventricular tachycardia is going to be a rate between 100 and 250. It's going to be mostly regular. You're not going to have any P waves, so you're not going to have a PRI. And your QRS complexes are going to be wide. They're going to be over 0.12 seconds. And then a form of ventricular tachycardia, or VTAC, is going to be torsades de pointes, which is a type of VTAC, and it presents a little bit differently. Your rate for it is going to be between 150 to 300. it's not going to have a regular rhythm. You're still not going to have P waves, and your QRS is still going to be wide. So this top one is VTach, very regular, very marched out, and then this is your torsades. It's called torsades because it has a twisting kind of appearance to it, and that is another fatal rhythm. Both VTach and torsades can have a pulse with them, so it is important to note if they do have a pulse or not, if this is a cardiac arrest rhythm or if this is a peri-arrest rhythm. Then you have VFib. VFib is everything's just kind of quivering, there's electrical activity, but it's not organized. You're not going to have any notable structures. You're not going to have a QRS, you're not going to have a P wave, thus you're not going to have a PRI or any kind of regularity to this rhythm. That's this bottom one. And that will never have a pulse, that is always a cardiac arrest rhythm. And that is all. Any questions, comments, concerns? Thank you.